Hey, Roberto, how you doing?
Yes, good.
They're changing the hours on you, huh?
Yeah, I can't understand. I can't understand. Actually, it's impossible. It's something very.
Well, you know, I forget the times in the time zone because I've got to deal with time zones everywhere, and man, I get confused, and sometimes
Yeah.
I'm an hour late. Sometimes, and people say, "Hey, when's the conference starting?" And I'll say, "Oh my God, I thought it was another hour." But this guy's a good teacher. This guy,
Yeah.
you'll see, Chandra.
Is Chandra again?
Yeah, it's again, yeah.
He's making a lot of.
You're lucky you can relax with artwork in Italy and expand your knowledge about neurosurgery. Hey, good morning, Chandra.
Good morning.
Good morning.
How are you on today? Great
Good.
to see you.
Nice to see you too. How you doing? I will be here in a sec.
So only in Italy we changed hour.
No, different time zone. Chandra, we're talking about the time changes when you in the neurosurgery world. You've got to learn how to determine the time. First of all, sometimes European times change, and I don't know why. Other zones won't. I'm confused. So what I like to do is check just before check on Google. What time is it in Italy or something like that? You know.
I think it's the same as the United States, John.
Yeah.
It's the 1 hour gain in the summertime and daytime.
So
Okay.
like yesterday.
Yeah.
They say more yesterday. I can understand. It's something. Once my father spoke to me about it, I couldn't understand. It's something really. Oh, it's like faith. It's not possible to understand.
Yeah. How'd they get the system? So Chandra, do you miss Miami? That was a long time ago, right? You're
Right
in Children's Hospital. It's a funny setting. It's like a suburban setting almost.
Mm-hmm.
Do you remember it?
Yes. Yes.
It's in like a neighborhood. It's not like downtown or like that.
Correct.
Yeah. It's when I first saw it, I said, "Wow, this is in a neighborhood." But they're still thriving. They're still doing well. It's a big.
Mumbai right now is virtually completely isolated.
Yeah, same. I think same everywhere.
Unless there is an emergency, we are completely homebound. Some of our colleagues are, of course, working all the time. But
well, you know, I just went to the pharmacy and they were closed. The pharmacy was closed because I guess someone went in that was contaminated. I don't know exactly, but they basically said close the pharmacy. I said, wow. But I think hopefully it's just temporary.
IPE had joined us, I think.
Are you there, Ipe?
I saw him on the chat.
Yeah, he's here.
Hello, how are you doing?
Hey, Christos, how are you?
I'm fine. I'm fine. Everything is fine. I'm submitting an article in Russian.
I want you to say hello to Chandra. Chandra, this is Christos. He's the head of the think tank of Europe of students.
Nice to meet you all.
Nice to meet
Right.
They're very active in Europe, Chandra, and I'm surprised to hear they're going viral in Netherlands. Zoom is going viral.
No, it's just a joke because, you know, this painting is actually a classical painting of Rembrandt, who was from Netherlands. So we are actually just joking. But
oh, okay.
Yes, Zoom classes are viral all over Europe now.
Oh, really?
For example, Stefan, that you met last time, the president of the think tank, He's studying in Sciences Politique in Paris and also in the LSE, London School of Economics, and they're doing classes through Zoom there.
Oh, okay. Yes, most schools seem to be adapting. I think it's the best platform. And it's free for the user, which is very attractive.
Mhm.
I think GoToMeetings you got to pay, and the other ones you have to pay, but this one is free. Ike, are you there? I see you. Let me text him here.
Just saw him briefly.
Yeah, yeah.
Hello.
Hey, Ike.
Can you see me, John?
Hold on. I can't see you. No, not yet. Oh, there you go. There you go. How you doing, Ike?
Uh,
I
hey, Prashant, how are you doing? All ready for today's package?
yes.
Chandra, could
Yeah,
you do me a
we're
favor?
ready to start whenever.
Okay, Chandra, could you do me a favor? Could you move your camera up? Because we can only see like part of your head. There you go. There you go.
Okay.
Okay, that's better. Okay, we'll start in a second. Okay, let's start now. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett from Miami for Neurosurgical TV. We have another episode, number 7, in the daily dose of neurosurgery education. And we're graced with the presence of Chandra Diopujari, a well-known educator, as well as endoscopist, skull-based surgeon from Bombay Hospital in Mumbai. Before we turn over to Ike and Chandra, let's meet the panel. Hello, Christos. Good morning.
Hello, good morning. My name is Christos. I'm a fifth year medical student from the University of Crete in Greece, and I'm really glad to be here today.
Thank you, Christos. Roberto, could you please introduce yourself?
Yes, hello to everyone. I am a medical student. I am a medical doctor actually in Italy, and I would like to be a neurosurgeon in future.
Welcome. You'll make it. Okay, Musindo, could you please
Hello,
introduce?
everybody. I am Augusto Jacinto Musindo. I am resident of neurosurgery in Mozambique in the Maputo Central Hospital.
Welcome, Musindo, and probably the best student we have. Okay, Guyo, Dr. Goy from China. Good morning.
Good morning, John. Hi, brother. And hello, everyone. I'm from Beijing. I'm the attending doctor of the Beijing Tsinghua Chang'eng Hospital. Hello.
You're welcome. You just did a webcast on the China Grand Rounds. Okay, let's see who else. Other panelists, Sunil, are you there? Perhaps not. Dr. Khalif, hello, good morning.
Hi, good afternoon from Kenya. I'm Khalif from Kenya. I'm a resident in 5th year neurosurgery and a frequent visitor of this. Thank you so much.
Very good. Welcome, Khalif. And Ike, why don't you take over from here?
No, it's Professor Chandra's show, so there is.
Oh, okay, Chandra. Thank you very much for coming, and it's all yours.
Thanks, John. So we'll pick up from where we sort of stopped yesterday. While discussing endoscopic skull-based surgery, we discussed how it developed, how the various approaches developed from uninostril to binostril, from the change to a 4-hand surgery to get us into a more extensive skull-based surgery, how it became possible. And we were on the subject of craniopharyngiomas when we decided to stop. And I just showed you this case, which is like growing in the direction of the nasal cavity and the best kind of scenario to approach the tumor. And we talked about once we have done an extended approach, once we have opened the dura and on the planum, and once you have taken maximum advantages of the corridor offered to us, and then we have the chance to separate the tumor from the normal pituitary, as you can see, and gradually take it out till we find that it is densely adherent to the pituitary stalk. We are trying to dissect the pituitary stalk with sharp dissectors and eventually manage to get the tumor out, as we said, from the ventricle as well as the whole supracillar region, and trying to keep the stalk intact. And as I told you yesterday, this patient required DDVP for almost about 9 to 10 months, and then we could take it off. So it worked. And as I said, we have not seen premorbid obesity in any of these patients who have been operated by the endonasal approach. And then we were talking about this larger tumor where part of the cyst was lying in the interpeduncular fossa. And here we decided to take the dorsum sellae out. This is a cadaveric dissection done at our place during our annual dissection course. And you can see that Amin was actually with us for this course. And you would probably find this picture in his recent book as well on cadaver dissection. And you can see that the tumor can be very safely removed from here without damaging any perforators. And this is the case example. So first we make the flap. Yesterday somebody was asking me, once you have made the flap and put it in the nasopharynx, then you start drilling this. And while drilling this, as you know, that we want to get to the dorsum sellae here. So you need to expose the clival carotids quite well. You need to make sure that you have gone all the way and removed the whole dorsum. The problem during that, I couldn't show you properly, but maybe I'll just show you in a moment. You are removing the last part of the dorsum there, and there is a rich venous plexus so that you can get some bleeding. Once you have stopped that bleeding, then you open the sella in the normal fashion, put the pituitary slightly forwards. You can push it to one side, as is becoming more popular these days, supposed to reduce the pituitary dysfunction if you do it that way.
Chandra, excuse me.
Yeah.
See the video because you have not shared. So we are.
Oh, you are not seeing the screen?
Yeah, I'm sorry there, I was preoccupied with promoting. Yes, you're not sharing.
Okay. So I need to.
Yeah.
I need to.
Yeah, just click on the share button at the bottom, like you did yesterday.
Yeah. Actually, it is on. Are we okay now?
Yeah, yes, it's better. Yeah, you want to make it a little bigger?
Okay.
Yeah.
Yes,
So
very good.
I think I will continue with what we are currently at. So
Okay.
making the flap and then opening the taking of the dorsum here, coagulating the venous plexus, and eventually opening the sella. And you can see that you can actually mobilize the pituitary to one side and then go behind it and start removing the cyst, as you can see from here. And you can dissect it well from the interpeduncular fossa, and this is the part which is actually the dome of the cyst, which is going into the ventricle. And this can be difficult unless the dome of the cyst collapses. So what we have started doing recently is something which I will show you in a minute. And this is how you close. You first pack it with the fat, then put fasciolata, and eventually the skull flap, the nasoseptal flap will go there. And this is how it looks post-operatively. I'll just try to show you one of the other cases, which actually we did when Amin was here for a workshop. And this boy, as you can see, has a craniopharyngioma with visual deficit, but you do not find any kind of sella. It's a completely non-pneumatized sella, as you can see on his CT scan as well. And here, with the help of navigation, we have been able to not only reach the sella and the plenum, but we have been able to excise the tumor completely. I can't share the video with you because we have lost it somewhere. But this is the post-operative picture, which shows that the whole tumor is out, and this is about 3 years after the surgery. What we have started doing recently in patients like the last cyst, which we showed earlier, we are doing a combined approach. What we do first is we do a ventriculoscopy, and we take out the dome of the cyst, and we actually, many of these patients present with hydrocephalus, so it is very easy to do that. So craniopharyngioma is presenting with raised ICT and a large cystic tumor with hydrocephalus, and especially to plan a proper endonasal surgery, it may take a little while. So we would first go ahead, like this patient, another 7-year-old boy who came with raised intracranial pressure. So we'll first go through a burr hole, go through the foramen of Monroe, open up the cyst, put in a reservoir, and the patient's hydrocephalus is taken care of. Patient has relief from the visual symptoms as well. You get enough time to work them up for endocrinological. You can get a proper MRI done, and then you are better prepared to go for endonasal surgery, which was done on about 4th day after this procedure, as you will see here. So we thin out the whole bone. We remove the bone from the sella as well as from the plenum, and then in a normal way, you would go for removal of this tumor. You can actually dissect it properly with the help of scissors, with the help of sharp dissectors, and eventually the whole. Now, the biggest advantage of this we have found is that the dome comes down very easily, and you do not have to do much dissection within the 3rd ventricle at all. The whole capsule is really falling down very nicely. And we have done now about 24 cases like this. And I'll just show you the last glimpse of the ventricle, where you can actually find the catheter, which was put a few days earlier. And you can see that the whole cyst is now coming out without much of an attachment. And this is the ventricular wall, and you can see the foramen of Monroe here at the top. This is the post-operative scan. This boy is about 4.5 years or so now, requires a small dose of DDA, VP, and steroids, but is on no other hormonal supplements. And we actually wrote up our experience of the last 20 cases in child's nervous system recently. You can probably have a look at this to see. The biggest advantage, as we said, is that we do not find premorbid obesity in any of the children. The need for long-term DDA, VP beyond 1 year has been less than 25%. And I think the third biggest advantage we find is that if we are decompressed from the top, none of these patients actually develop postoperative CSF rhinorrhea, which is always a bugbear for this kind of surgery. Yesterday, somebody was asking me, when would you do what is the contraindication, or when would you do a transcranial surgery? So this is one example. This is a young man who has presented with unilateral visual problems. And you can see that the cyst is lying mainly on one part of the paracellular region, in the temporal region, going into distorting the brainstem considerably. And I think this kind of a patient I would certainly do by a transcranial approach. It is going into the opposite temporal lobe as well. And I do a simple pterional approach, split the sylvian fissure the usual way. And then you are seeing the third nerve on one side from where the cyst is being removed. And so yes, there is a definite indication for patients to have, you can see the decompressed optic nerve. You can see that part of the cyst wall is still attached somewhere around the tent. And this is where between the opticocarotid angle. So you can use all corridors and make sure that the whole tumor comes out. And the biggest advantage is that you can put an endoscope again, make sure that you have been able to take out the whole capsule from almost all crevices through all the corridors. And it helps you to make sure that you have been able to remove the tumor completely. And there's a very nice example of how this can help you to make sure that you have done a complete excision. And this is a post-operative scan of that gentleman. Again, a fairly good result, I should say, for a large craniopharyngioma. So yes, there is a definite role for open microsurgical procedure. And I think a largely calcified lesion a patient has had previous vascular injury in a recurrent tumor, and most importantly, intraventricular craniopharyngiomas like this one. You can see that there is a clear plane of cleavage. There is parenchyma. You can see that there is a leaf of hypothalamus which has not given way. And this is a purely intraventricular craniopharyngioma. And this can be tackled either endoscopically or microscopically, but transcranially. You wouldn't go transsphenoidally for this kind of a lesion. And this is another patient who has had a previous injury to the carotid during previous surgery. And though the previous surgeon had not mentioned this, when the patient came to us with a recurrence, we realized that there were some areas of infarction. We repeated an angio and saw very clearly that there was carotid injury, and we decided to go for this case by transcranial approach. Chordoma, I think, is another indication which has become very, very popular for endoscopic skull-based surgery. Again, because of the fact that many of these lesions are extradural, they are in direct line of your attack. Most of them take origin from either the top or the middle of the clivus, and many of them don't go beyond the suture, the petroclival kind of a suture. Sometimes the chondrosarcomas can go more eccentric, but the chordomas usually don't. But you may find big chordomas, and we'll talk about that also. But this is a young girl who presented mainly with succinyl paresis. You can see a strictly midline chordoma. You can see that it is coming from the upper clivus. You can see that it has occupied the sphenoid sinus, and it has occupied the top of the clivus here. You can see the destruction of the bone on the coronal and sagittal CT scans, which are absolutely necessary. And this is how you go for it. You first open the sphenoid sinus. Of course, you take the keel out. And most important thing is, when you want to remove a chordoma, you want to reach the normal bone. And I think that is possible by this approach much easier and much better way than what you can do by a transcranial extradural approach. You can see virtually the whole tumor has been skeletonized. Is the picture seen quite okay?
It's okay
Yes,
for me.
Prof, it's very
guys?
clear. It's very
Right.
clear. Beautiful picture.
So the most important thing is you must go clear the tumor from below. You must clear the tumor from the sides, of course, taking care of the clival carotid. And we will come to the fact when the carotids are either displaced or involved. And we are trying to remove this tumor after separating it from everywhere. And you can see that the extradural component is coming out quite well. Part of the mucosa is coming out with that. And now, after this chunk is out, you will probably come across some of the tumor which has broken the dura. You can start seeing the CSF and some venous bleeding coming from the bottom. You can use patties like what we usually use, and therefore the 3-hand or the 4-hand approach comes into use when you have this kind of a situation. Yesterday, somebody was asking me about curates. Curates are used, but as you can see, the curates are being used mainly as a dissecting tool and not really to curate as such. And most of the work is done with the curved suctions rather than the curates nowadays, once we have got hold of that. So this bleeding we had to stop with, as you can see, the flowable hemostat, and that worked reasonably well. And eventually we could get a good control and complete this tumor removal. There was a very, very tiny tear in the dura. This is the immediate post-operative scan, and this is the 3-month post-operative scan. We are in touch with the patient is seeing the oncologist regularly. They feel that the patient can be observed as there is no residual tumor seen. We recently have proton beam facility in India, so we decided to use that as and when necessary for this particular patient. Now here is another chordoma which is coming mainly from the middle third. You can see that it has gone intradurally very, very clearly, and it has gone on both sides into the cavernous sinus. So this is difficult. This is something where You have to be very careful on the sides, but as far as top and bottom is concerned, you know that you have to enter the sphenoid to get to the top of the tumor, and you have to open you have to come up to the normal dura below this. So your dissection has to be all the way down. You can see a tunnel has been formed so that we can get to the normal dura here, and that is the end of the tumor, and that is the lower pole of the tumor, which is now being gradually removed. Once we have done that, uh, you will find that the top of the tumor, the back of the sella, the dura is seen, the clival dura, and that is being coagulated on the side of the posterior cavernous sinus, and tumor is coming from there as well. And now you see that you have entered the cavernous sinus. You can see the carotid here, and the tumor lateral to the carotid also came out nicely because the tumor gave us entry into the whole cavernous sinus quite well. And both the sides the tumor could be taken out, and you have now the sella being or the whole cavity being packed really. So this is how it looks at the end. You have seen the intradural structures here and the cavernous sinus on both the sides, and all that has been packed. And this is the post-operative picture. This lady improved in her third and sixth nerve palsy very well. Lower part of the clivus becomes more difficult. Here we have developed a laryngeal flap. We take a reverse U-shaped incision, and then you have to expose this whole area right down to the C1. And this is a cadaveric dissection to show that you can expose quite well laterally. But if anything is going, like the other day, I was saying that anything going beyond the hypoglossal canal, you cannot approach. Anything going beyond the eustachian tube, it would be difficult to approach at a little higher level. This is the patient who also had to have a fixation because the condyles were also destroyed in this particular patient. A more common problem in India is the odontoid invagination, as we call it, the basilar invagination, where the compression is mainly anterior. And there the transoral surgery causes palatine dysfunction very commonly. And therefore, we have started doing endonasal. Most of these procedures are done after the posterior surgery has been done. And if there is a persistent compression, cadaveric studies have shown that you can see it very nicely, especially at the top, which can be a difficult thing to do in transoral surgery. And therefore, we usually go by the Kasam's concept of nasopalatine line. If you have the tip above the nasopalatine line, you can do it very easily with the transnasal approach. Otherwise, we are not so puritanical. We can do actually transnasal and transoral alternatively. Usually, if you are putting the endoscope through the nose, your instruments go through the mouth. And if you are doing the endoscope through the mouth, then your instruments go through the nose. So we make a binostril corridor and use oral cavity and use both the corridors to effectively remove the odontoid, like you would find in this video. So lower part of the pharynx has been divided in the center, and you have to be dependent on navigation. You start drilling right from the bottom and then go up to the top till you keep on checking till you have made it into an eggshell, and then you start making sure that you have reached the atlanto-occipital membrane, the anterior membrane. And once you have done that, you will find that the sides are being taken off now. And eventually the dura actually falls down into your cavity, and you have a very good decompression done over here. The biggest advantage is patient can start eating and drinking within first 48 hours, which a transoral patient takes almost 5 to 7 days to do that. This is a free flap, and then the U-shaped flap comes down onto the. So we wrote about our technique in World Neurosurgery a little while ago. You can probably get some idea about the details of the procedure from there. And this is what you can achieve by doing a purely transnasal procedure. But as I told you, we have not remained so puritanical now. We can do either transoral or transnasal in the patient. I think, should we have some questions now, or shall I just go ahead with the corona concept of the coronal plane? I think this is something where a ENT surgeon takes a lot of precedence because they are more familiar with the landmarks, but all of us have to be familiar with the carotid artery landmarks. And many of us will have to do things like lateral sphenoid CSF leak, lesions going into the cavernous sinus. I think orbital tumors can also be effectively done, which are medial to the optic nerve, and pterygoid and Meckel's cave lesions can also be done if you can manage to reach there once you are. And the main thing, as I told you, you have to follow how the carotid artery goes. I'll just show you 3 cases, one of each, so that you get a general idea before we start question answer session. So this is a V2 schwannoma. The patient presented only with the pain just under the eye, and you can see that there is a cystic large lesion over here. And the best way to tackle is, of course, to go by the inferior approach rather than going by a transorbital or a transcranial approach. And you can see as soon as you get into the maxilla and remove the posterior maxillary wall, you will be into the tumor, as you will see very clearly here. So the corridor is different. You are not going into the medial compartment. You are going actually at the back of the maxilla. You enter the maxilla. As soon as you go to the back of the maxilla, you are seeing the tumor. The thinned out bone has been gradually, the shell has been taken out, and then the tumor is being gradually debulked. Once we debulk the tumor enough, this is the debrider which Ike was talking about, and you can actually use the coablator to achieve hemostasis from time to time. And then eventually we are subperiosteally, we are creating a plane and removing the tumor all the way. You can see that the back wall of the orbit side wall of the orbit is seen where there is no bone now, and you have got a very nice plane to remove the tumor almost completely. I think it has virtually come out of there, a little bit of sharp dissection, and it is, the whole thing is out. And this is about 4 years now again, and the scan looks pretty good, no residual recurrent lesion. If you want to go transpterygoid, then you must understand where your median nerve is, where your V2 and V3 are, where is the lie of the carotid before you get into that. So this is a patient, one of our very good skull-based surgeon colleagues removed a trigeminal schwannoma, but it recurred in a year's, 1.5 years time in the pterygoid fossa, and we decided to remove this by endonasal approach, again going to the back of the maxilla. And the debrider, as you know, works very well to do that. And you have created flap just in case it becomes necessary. You have examined the lateral aspect. Now removing the, you can see the optic nerve here quite well. The lower part is being removed, and you actually, as soon as we get the mucosa down laterally, we directly enter into the tumor without actually seeing the carotid completely. So we first decide to debulk this like we would do in any schwannoma. And virtually a complete removal could be done. You are onto the lateral wall already. You need to use electromagnetic navigation if you are using navigation here, because it is malleable and it can still give you a good idea even in a coronal plane as to where you are. And a good complete excision could be achieved in this tumor as well. I would probably show you the last case. Meckel's cave case where you need to make sure that you have gone lateral to the median and you have gone completely onto the side, like in this kind of a patient. But again, we thought this was probably a good way to remove this lesion because you could go through the inferior approach quite well. And this actually turned out to be just a encephalocele, actually in a young patient where there was some history of trauma. And this was causing the patient some kind of a obstruction and seizures. And maybe this could have been done by the transcranial route also, but this turned out to be equally good. We could remove the whole mass and could repair it quite well, as you would see on the post-operative scan. Basically, I think if you are going to do extensive skull-base endonasal surgery, what you need to know is that how to make various flaps. The basic flap is the HB or the Haddad Backstase flap, which comes onto the from the nasopalatine artery, the septal branch. Usually you would prevent that, you will preserve that, which is just below your, before you enter the sphenoid sinus, make sure that you have preserved that. You make sure that what is going to be the base of your flap and don't allow that mucosa to be damaged. What we now do is that even if it is not required, we just make a mark on the top of the artery and on the bottom of the artery, what our colleague calls a rescue kind of a flap, where he just makes 2 incisions and leaves it like that, which can be deepened later on. But that makes sure that you are not going to damage that part of the mucosa in future. And free repair, you usually need a 3 layered repair if you have a profuse CSF leak. So the first layer is usually fat or duragen or something like that. The second layer is usually fascia. And then the third layer is actually the nasoseptal flap. You may use cartilage if the defect is too large, and especially if you have opened the ventricle, we try to use a cartilage. So that's, I think the fibrin sealants systematic literature review has shown that it has certainly reduced the number of revision surgery for CSF leaks. And we'll come at the end to the complications of this procedure. I think the nasal complications we briefly talked about. Initially, you can get a lot of bleeding. The most important thing is that you have to be very patient while you start your surgery. Make sure you have created a good enough corridor so that your instruments do not damage the mucosa every time you come in and go out. Irrigate profusely, irrigate profusely. Like the other day, I was saying that he does most of his surgery under water. You really need to create that kind of atmosphere, which makes it much easier, not only for you to see, but gives you a good plane of dissection. In the sphenoidal component, I think the septation of the sphenoid sinus must be studied properly because many of them end on carotid, and you need to be prepared for that. And you need to make sure that do you really want to expose the carotid or not, and go accordingly. And in the sella, I think what is important is unnecessarily you don't want to open the cavernous sinus or intercavernous sinuses, but in a extended approach, you have to do that, and you should electively do that and ligate the sinus directly in the midline. If you try to go laterally, you can damage the hypophyseal arteries, inferior hypophyseal arteries, which might jeopardize the patient's vision and cause hypothalamic dysfunction unnecessarily. I think in paracellular, supracellular lesion, the complications are the same as for any craniotomy, the cranial nerves and the optic apparatus complications. I don't think I need to talk separately on that. Main thing is cavernous sinus. Yes, you need not be you need not give a lot of pressure on the cavernous sinus wall. Otherwise, sixth nerve injury can occur, and it does occur from time to time when you try to take the tumor out of the cavernous sinus, but it usually clears up quite well unless you have really damaged it badly. Endocrine function, I think endocrine results of we are right now trying to get data out of that, but our endocrinological cure for functioning tumors has definitely improved. And I think pituitary insufficiency has reduced. This is what our impression is. we should have some figures to show you soon. Special consideration in children. I also do quite a bit of pediatric work in another children's hospital, and we get to see sphenoidal encephaloceles, which are very difficult to treat by craniotomy alone. So we have actually started repairing these through the transnasal approach. I'll just spend 2-3 minutes on that. This is one patient where you can see the size of the defect, and you can actually see a large encephalocele coming down. Basically, all this can be repaired, and you can actually get a very good nasoseptal flap even in this kind of a patient. Gradually, I think we have come to a stage where we are now comparing results rather than just talking about feasibility and talking about complications. And this is our experience of about 150 cases, which we did till 2018. There are about 10 or 11 cases added to this afterwards. And I would say that at least unless you have done more than 50 extended approaches, you have done more than 100 pituitaries, you should not try to get into any lesion which is lateral to the carotid, like this chordoma. It is much easier to do this by a proper Dolenk's approach, or while dissecting that day, uh, uh, I very nicely showed. Once you start reflecting the dura from the meningoorbital band, you actually come onto this kind of a tumor very, very easily without disturbing any cranial nerves, and you can remove this quite nicely from there. And I think the other thing which also helps, especially in lesions like when you are not sure if the optic nerve is displaced or optic nerve is lying over or under the tumor, DTI comes to your use. This is one patient where we first thought that we'll go endonasally for this orbital tumor, and then on the DTI showed us very clearly that the tumor was actually lying lateral to the optic nerve, and therefore we abandoned this and went for the transorbital approach. So I think I would summarize by saying that expanded endonasal approaches are appropriate for appropriately selected cases, work very well. You must have a vascular Doppler. You should have a familiar two-surgeon team as far as possible. If you do not have a good ENT surgeon, I think if you have a good neurosurgeon colleague, you can train him and you can exchange your positions from time to time. And I think the future tools will probably change the current equation of surgery, especially the robotic devices are probably taking away the need of ENT surgeon by keeping the endoscope in proper place all the time, and which you can easily manipulate. And I think there is no substitute for studying this subject with simulation and cadaver workshops, and it should proceed in a phased manner from pituitary to midline skull base extradural, and then eventually to paramedian lesions if you are still interested. Thank you.
Okay, thank you very much, Chandra. So Ike, do you want to lead the discussion?
Yes, maybe I can lead the discussion.
Yeah, Ike, you there? Or perhaps not. Okay, maybe he stepped away. Any comments or questions from the panel?
Prof, I wanted to ask a question on the cases you did, the craniopharyngiomas. If you find that a tumor is attached to the pituitary stalk, would you sacrifice the stalk or would you leave a tumor behind?
It would depend on a few things. Number one is, what is the preoperative pituitary status of the patient? If the patient already has pituitary hypopituitarism, I would have no hesitation in sacrificing the stalk. In a patient with normal pituitary function, it will depend on what age I am seeing the patient. In a child, I try to preserve the pituitary stalk because there are alternative methods of treatment, focused radiation, which we can give pretty good results. So my current concept is that in a child with normal pituitary function, I would preserve the stalk. Otherwise, if it is a recurrent case where all other treatments have been tried, I would have no hesitation in cutting the stalk, and especially in patients who already have damage of the pituitary function before we go for surgery. I think in those patients, you can probably safely cut the stalk for a complete resection.
Yeah, excellent talk, Professor Chandra, as usual. A lot of experience talking there. Yeah, going to the carotids is definitely.
Sorry,
I can't hear you.
Can you hear me now? Can you hear me?
Yes, we can hear you now.
much better now.
Yes,
I think I need to be staying very close to this computer.
yes.
I don't know what happened with this audio, but you know, I was seeing all those challenging cases being done by Professor Chandra, and I mean, all appreciation to him. So we are developing, as I was telling you, we're trying to develop this thing called hybrid neurosurgery, and his experience would be invaluable for us. We're trying to change the way things are right now. So we are not going through strictly endoscope or exoscope. We're trying to do a combination, and we're trying to do many instruments which are combination. So for a bipolar scissor and things, suction bipolar or comparator combination. So this is the future, and so I mean we would definitely like Professor Chandra's experience to be helping us with this.
Sorry, we're having trouble with audio. I'm sorry. Sorry.
Yeah, I couldn't hear the whole thing, but I appreciate IAP your efforts at I think the future of well, for that matter, all surgeries, but endoscopic surgery, where you can see a lot and you think you can do a lot, and sometimes you have to stop because you just don't have a proper instrument. I think those kind of situations will probably improve very, very fast with innovative people like you. And I'm really looking forward to a lot more happening in that aspect very soon.
Okay, then guys, I'll carry on. I'll do evening rounds and then carry on home. So I have to come to the hospital almost on an everyday basis because we have still inpatients. I hope we can discharge of all of them, but the rehab patients, of course, I cannot. So maybe for a month we'll have patients. So I'll have to come to the hospital every day. It's scarier and scarier every day because all the masks and this PPEs. And for the first day today, I have worn the mask, but things are going scary. I tell you, things are really going scary here. Although Nepal is not really affected, and I hope it stays that way. All of you stay safe. God bless. Thank you, Chandra, for coming down. So it's a pleasure.
Thanks, Aip. I think in future, as and when you think, we can do maybe 2 intracranial endoscopy sessions, one on hydrocephalus and one on maybe cysts and tumors.
You could
And
do,
then
do this tomorrow.
Okay, what do you want to do tomorrow, Chandra? What do you want to do tomorrow?
I can do tomorrow. I can maybe do hydrocephalus tomorrow, and then if
Okay.
we want to do it in continuity, we can do the tumor census day after tomorrow.
Okay, excellent. Hydrocephalus. Any more comments or questions from the panelists? Now's your chance. Chandra's here.
We can do hydrocephalus and cysts. I think we'll do a combined thing.
Okay, and says, okay.
Yeah.
Thank you so much, Prof. Thank you so much.
Thank you.
Okay, any other
Any
comments?
Comments?
Comments, please.
Thank you.
Okay, thank you, Amanata. Do you want to say hi, Amanata? Introduce yourself. I don't think we met you. Part of the value of these sessions is networking and meeting people.
Yes, I've been coming more or less regularly lately, but I'm Aminata Sala. I'm originally from the Gambia, training in Zimbabwe, currently in Namibia, waiting out issues in Zimbabwe in the healthcare system, plus now COVID. So yes. I'm presently in Namibia. So greetings from Africa.
Thank you for coming.
It's a privilege to be here and to attend these because I really miss all, the training and the activity.
Great. We hope to see you tomorrow.
Thank you.
Okay, Dr. Hufang, Manuel from Russia, are you there? Is that you, Manuel? Perhaps not. Okay, Dr. Deopujar.
Hello, John. How are you?
Okay, go ahead, Manuel. Go ahead. We want to see Moscow. Can you turn your camera on there?
Now, what?
Can you turn your camera on so we can see Moscow?
Yes. Wait, give me a second.
We want to see the snow.
No, stop snow. Stop now. I'm gonna
Okay.
turn.
Okay. Okay, perhaps, well, perhaps it's a little difficult.
Seem to have lost him.
Oh, okay. Okay. Any more comments, questions?
Okay.
Okay, very good. Thank you, Chandra, and we'll see hopefully everybody tomorrow. Thanks, Hype.
Thanks. Bye for now.
Bye-bye. Everyone's quiet today.
Thank you, John. Thank you.
Thanks.
Yeah, thanks all you guys for coming. We're getting a good crowd.
Thank you. See you tomorrow.
Yes, thank you. Hey, how's everybody doing in your part of the world? In Miami, it's like everywhere else, it's shutting down. I went to the pharmacy today. It was closed to get coffee. Actually, it's a big store, which the neighborhood depends on. I don't know how this neighborhood is going to get through without a pharmacy. It's one of these pharmacies that, hey, Sunil, it's one of these pharmacies that has everything, you know. And to close that in this neighborhood, geez, wow. How's it like where you're at, Sunil? Is it okay?
Oh, it's good here. It's much better than before here.
Yeah, it's getting better. That gives us hope, I think.
And I'm very lucky. Like I'm in the Suzu. Like here, like most of the peoples are not affected.
Oh, good. Okay. Hope it stays that way. Sanjeev, we haven't met you yet. Hello, Sanjeev Kumar Thakur. Hello.
Sanjeev Kumar Thakur.
Can you hear me, Sanjeev? Perhaps not.
Yeah. Hi, John. Yeah. Hi, John.
How you doing? Welcome. Okay.
Hi, John.
Okay. Yeah, I'm seeing you now. Okay.
I heard the presentation. It was quite informative. Yeah.
Yeah.
So you remember we Nobel?
Yeah. Your sound is kind of breaking up. Yeah, unfortunately. So in a situation like Sanjeev, what you need to do is turn off the camera like I'm going to do right now. I'm turning off my camera. It conserves bandwidth, just so all you guys know.
Okay.
Yeah, you see, Sanjeev, see how I turned off my camera? Turn off your camera and you'll get better sound. You know what I mean, Sunil? Watch me. I'm going to turn off my camera, and that will give me more bandwidth. For if I'm having problems with bandwidth, turn your camera off. Does everybody understand that? Why don't you try it, Sanjeev? Turn off your camera.
Yes, John.
Yeah.
Yeah.
Okay.
I put off.
Okay. We can. It's better. It's better audio now for you.
Yeah, now it is audible. So, hi, John.
Hey, how you doing?
Remember, we met at Nobel. So, I heard the entire presentation by
good.
The Professor Devpujati. And he is a very well-known person in endoscopy.
Yes.
And this, along with Professor Ibe, we have also been doing a lot of surgery over here. So, it was quite informative.
Good.
And I hope to attend more of these kind of meetings.
Yes.
I'll try to be regular.
Are you? Where are you, Sanjeev? Exactly in India.
I'm with Professor Ibe. I'm with Professor Ibe at Nobel.
Oh, okay. You're excellent.
If you remember, we met at Nobel.
Yeah. Oh, yeah. Okay. Now I remember. How was it? Yeah. I guess I was saying it's kind of.
Yeah, with Binod Felix and all. Yeah.
Yeah.
So with Binod Felix, we had done one presentation in Viratnagar.
Yes.
Yeah. So I'm assisting. Yeah, I'm assisting Professor Ipe with the skull-based surgeries.
Okay.
So I'm his ENT guy.
Yeah. Are you there? Are you there for a couple of months or?
No, I'm there. I'm associate professor over there. I'm a faculty.
Oh, okay. Okay.
And,
You're there. Yeah. You're there permanently. Okay.
Yeah. Yes.
Okay. Well, welcome.
Thanks, John.
Okay. You know, we gotta, okay, Dr. Kalp, are you there?
Yes, I'm here only.
Yeah, hi. Could you want to introduce yourself to meet the people?
Yeah, of course. Well, I'm a second year neurosurgery resident. I work with Dr. Dev Pujari only, Professor Dev Pujari. I'm his resident. I was, yeah.
Oh, excellent. Excellent.
Yeah, I work in Bombay Hospital itself with Dr. Dev Pujari, and I was just, I checked in yesterday also. I listened to the presentation. It was good. It's always a treat to listen to him. So
I know. What a teacher, huh? What a great teacher.
Yeah, so I never leave the chance to listen to him. So even if I work with him, I checked in and listened to the presentation.
Well, I know. When I first saw him speak, it was a couple of years ago. I certainly noticed his quality of teaching is like really good. And I knew if I was a resident, I'd want to watch him.
Yeah, so it's a treat to watch him operate also. I mean, he's a good teacher, so I feel fortunate to work with him.
Well, we hope to bring him to a lot of people, especially in the next couple of months where most of us are housebound. So it's a good chance, I think, for us to meet Dr. Dev Pujari. And as you know, it seems endoscopy is a hot topic in neurosurgery. A lot of people want to learn about it.
A lot of people want to learn at the same time. Dependence on, two people, some ENT people also needs to be there with you. At the same time, you need to get oriented, well versed with the nasal anatomy. Even if you are ENT guy, you need to have that much awareness. So I think it is a hot topic and it needs lots of dedication and time. Its learning curve is slightly longer. This is what I feel.
Yeah, it's well, we hope to bring them as much as possible in the next while. Okay, gentlemen, thank you all. We have a conference now in Latin America.
Yep. Okay. Thank you.
Thank you, Thank you very much, Sanjeev, for coming. Lucindo,
See you tomorrow.
Thank you. Buongiorno.
Okay.
Ciao.
Okay, ciao.
See you
Thank you, everybody.
tomorrow.
Thank you, everybody.